A client with appendicitis and the right lower quadrant pain. Should you worry? No, appendix is on your right side, right lower quadrant. This is where appendix is located. And you have itis, I should expect pain. Just because it's an appendicitis doesn't mean I have to worry about it. There's nothing. I'm not telling you patient has peritonitis. There's no abdominal rigidity. There's no guarding. There's no peritonitis. I've not said anything. Patient has appendicitis. Appendicitis will give you appendix pain, and appendix pain is on the right lower quadrant. So that's what you expect for the patient to have pain. A client with diverticulitis, another itis, with 8 out of 10 left lower quadrant pain. Yeah, diverticulitis is on the left lower quadrant. And there's itis, so you should get pain. It's 8 out of 10. Okay, it's bad for the patient. It's perception. Pain is perception, but we believe the patient. Is the patient in shock? Is the patient has guarding, rebound? You're looking for abdominal rigidity. Abdominal rigidity. Rigidity. That word is your friend. Or rebound tenderness. Or peritonitis. They won't use the word peritonitis, but all of this indicate peritonitis. You should not worry about this patient unless I see this. If I see this, yeah, I have to worry about that patient. Okay, guys. A client with cirrhosis, an albumin of 2.9. To you, the liver make albumin. You need your content. Liver make albumin. Therefore, if there's no, the liver is not functioning well, your albumin will go down. I just want to give you the content for that. If you have liver cirrhosis, these are the lab work you should expect. Okay. Albumin is low. AST, ALT, high. Bilirubin, high, right? Platelet, low. That's all. And they have ascites. Okay, you expect clay-colored stool. It's all fine. This is what you expect, so don't worry about it. The client in a prone position after lumbar puncture. Okay, the lumbar puncture, when you do that, they go into your spine on your back. They do it. When you finish, you have to put pressure on it. Otherwise, you have CSF leak and you get more headache. Of course, if you get headache, you give them fluid management. But I don't want you to get headache, and I want that puncture to seal. Therefore, you should lay on your back, supine. Laying prone is not good, so I need to see you. Okay. A client with pyloric stenosis and a palpable mass on the right upper quadrant. What do you think, guys? Do you worry about this? Olive mass is located on the right. I did not put olive mass there, but the olive mass that you feel for pyloric stenosis will be on the right side, on the upper right abdomen. Therefore, this is an expected finding. Don't worry about it. Okay? Don't worry about it at all. That's an expected finding. So that's not a problem. A client on warfarin and INR of 6. This is too high. Supratherapeutic. You need 2 to 3 or 2.5 to 3.5. 6 is too high. So I got to see you. Probably you bleeding. A client with intussusception with blood thin mucoid stool. What do you guys think? I don't give it to you. I just should describe it. Blood thin mucoid stool. So it is current jello stool. That's expected. So don't worry about it. The client on methagonovin and a BP of that. What do you guys think? Pharmacology. OB pharmacology. I taught you this already, so. This is contraindication. Uncontrolled hypertension should not get this medication because it causes vasoconstriction. and then that will give them stroke. This blood pressure is uncontrolled. This is a medication that causes vasoconstriction, and that will worsen the problem. So you should avoid it. As a client in oxytocin and cis contraction in 10 minutes. Once again, that's the way they will set it. What do you guys think? 6 contraction in 10 minutes. How many contractions should you get in 10 minutes? 2 to 5. This is tachysystole. The uterus is contracting nonstop. It will burst open. Therefore, we need to stop the oxytocin right away. That's bad. So we got to see this patient. Okay, guys. So that patient needs to be seen. So it's a priority patient. And that is the there's 19 more, but it's okay. I think you guys get the point. Unless you want to keep going, but you get the point. These questions I made up. If you want to go back, I mean, I made it up, it's just like, just to show you how they can give you a bunch of prioritization questions. I just like, it came into my mind. I know the topic, so I can tell you what is bad about the problem. So, a client on heparin and a platelet of 100,000. Okay, what do you think? Should you worry about this or just ignore it? This is heparin-induced thrombocytopenia. We call it HIT. So you better see this patient. You better, because they like asking that. Heparin-induced thrombocytopenia. And the problem with this is thrombosis, no bleeding. Bleeding is number 2, but number 1 is clots. So they will get stroke. That is it's a little bit counterintuitive, but problem with HIT, the platelet is too low that it will clump and it form a clot problem. So stroke, DVT, and other things. So you have to see them. And I put it there so that in order for knowledge check, a client with HIT prescribe enoxaparin. What do you think? Should you see this patient? It's a trap. I intentionally put it there. Yes, you need to see this patient because they will ask you the same question. A patient who has HIT, and then they'll give you multiple choice. Which anticoagulation will you give him? There is no more need for them to get heparin. Enoxaparin is a form of heparin. So you should not give them any more heparin. So you should see these patients. So this is also heparin. So you should not get heparin. So I need to see this patient. I need to see this patient. Your better choice is maybe Coumadin or the guys with the Zabans, the factor 10 direct inhibitors, Agatobans, Episibams, all those guys. But don't choose any heparin or heparin-based medication. A client post thyroidectomy complaining of swallowing problem. Do you have to see this patient? It's just a thyroid, it's sore throat. Why do you have to worry? Should you? I'm just checking what you guys think. Yeah, this is an airway issue. I know they taught you, I don't know, everybody think thyroidectomy, worry about bleeding. Most books say bleeding. Clinically, the time they will become hypotensive, they already dead. A little bit of blood will press on the trachea and they will start bleeding. They will start having airway issue. So if I draw it, the trachea is just sit here like that, and then the thyroid is here. If you take it, there will be small blood that bleed, it will push on the trachea right down, and they will have swallow problem. The other way they can give you is stridor. They have a stridor here. So before the blood pressure goes down, they have bled too much that the airway is already collapsed. So I got to see this patient. Swallowing problem, yeah. A client on allopurinol and a temperature of 103 with muscle rigidity. You should not let this patient go away. That's deadly. We talk about it. One of the hot guys. This is what? NMS, okay? Allopurinol, antipsychotic, temperature 103, muscle rigidity, everything is up, is emergency. You have to see this patient. They can be the same. They tell you, patient just had surgery, muscle rigidity, tachycardia, malignant hyperthermia. It's the same thing. Third one, somebody had thyroid surgery, tachycardia, temperature 103, muscle rigidity. Yes, thyroid storm. Same thing. Somebody is taking SSRI and go and take St. John's wort. Yeah. Or MOIs, and all of a sudden, tachycardia, muscle rigidity, temperature 103, that is serotonin syndrome. The same way they will ask that question. But this one is antipsychotic, is the same thing. So you better see these patients, these 4 patients. A client on warfarin, taking 1 hour after sucralfate. Think about it. He took his warfarin 1 hour after sucralfate. Is that good? Do you want to see this patient? Sucralfate. When you take sucralfate, nothing can be absorbed in your stomach anymore. It coats everything. So you should not take anything no more medication. You got to wait minimum 2 hours. You take the medication 2 hours before you take the sucralfate, or after you take the sucralfate, wait another 2 hours. So this patient need to be seen. It's a priority. You got to intervene. So intervene. A client taking iron tabs for anemia and orange juice. What do you think? That's what they teach you, that you should take oranges with iron, right? Not antacid or anything like that. So these are the things they ask all the time. So I'm just trying to get you guys not to forget them, okay? A client, 38 weeks, okay, with variable deceleration. Variable deceleration. What do you think? Should you let that one slide? Yeah, I don't know about it. It's bad. Variable deceleration, use your VCHOP and you can see variable deceleration. It's not good. It's unpredictable. We should see that patient, please. Don't let that patient go away. Variable deceleration is bad. The client, 34 weeks with sudden painful dark blood from the vagina. What do you think? These are the things you can use for your next generation. The same thing they will give you is just content that you hear the buzzwords is, oh, I know this. This is what it is. You make the diagnosis, then you manage it. This sudden, okay, painful, dark blood, placenta abruption. Please see this patient, okay? A client with sickle cell disease with jaundice. Should you see this patient? Remember what sickle cell, what it does. That is the trap. So remember what sickle cell does. Sickle cell patients, they are anemic, they have jaundice, their hemoglobin can be 8, that is expected. They basically destroying their blood cells all the time. So don't worry about it. That is okay. They usually jaundice because the hemolytic anemia, they have bilirubin buildup. So that is expected. Once again, the only time you worry about sickle cell patient is when they have enlarged spleen. When their spleen is big, that is sequestration, that's hemorrhage. Or when they are pain, they came in with pain of 3 and now it's 10. That is infarct, complete infarct. Otherwise, even in crisis, it's okay. We manage the crisis. It's never an emergency. That is okay. But if they come in, their pain is 4, and all of a sudden it's 10. It just progresses then that means you have to see them. Or their spleen is enlarged. Otherwise, they have a small spleen, okay? They have infarct, they have strokes, it's normal. They have jaundice, it's normal. They have anemia, that is normal. If they give you a sickle cell patient and they said hemoglobin is 8, don't see them, okay? That is what I expect them to be. It's not going to be 14, sorry. So don't see them. Jaundice is okay for them. A client with schizophrenia and auditory hallucination. Do you want to see this guy? He's screaming for you. Better go and investigate the content of auditory hallucination. Every hallucination, you should not reinforce it, but redirect the patient and then bring them to reality. Auditory hallucination, you better find the content of that. Otherwise, they may kill themselves or kill somebody else. Anybody with schizophrenia with auditory hallucination need the content of that hallucination to be investigated. Apart from that, if they say they see Jesus, tell them it's fine. Don't say it's fine. Just say, okay, I don't see Jesus, but this is what I see. If they said they see somebody crawling on the wall, you said, I don't see that, but this is what I see. You bring them to reality. If they said they telling me things, the next question is, what exactly are they telling you? I want to know if you want to kill, so that if I know you're going to kill yourself or kill somebody else. So I need to see this to find the content of the hallucination. I think I just beat to the bush. Let me see. 8 more, then we're done. Sorry, guys. I just took an hour. A client with pericarditis complained of chest pain relieved by leaning forward. What do you think? That is the definition of pericarditis. If you have pericarditis, they have chest pain. Don't let this bother you. Don't let the chest pain bother you at all. That's why I said when they give you priority question, don't look at the other thing. Look at the problem. I have pericarditis. What is the issue with that? I have chest pain when I lean forward. Well, that is what pericarditis is. You have chest pain when you lean. You have chest pain that is relieved by leaning forward. The reason why they do that is this is their heart, and the pericardium is all thickened. So there's a friction rub. So when they take a deep breath, the friction causes pain. In order to relieve the pain, they lean forward to open the chest so that they can take a deep breath. And so they would like to lean forward to relieve the pain. That is expected. That chest pain is what I expect them to have, and it will be relieved by leaning forward. That is good. If it's not relieved by leaning forward, yeah, it becomes a problem. But it's relieved by leaning forward. The only time you should worry about pericarditis is when they have hypotension. That means it's becoming what? It's constricting the heart. So the heart cannot pump anymore. So their blood pressure is decreasing. What do you think? That is tamponade. They will have JVD. That is tamponade. Okay, they have muffled heart sound. That is tamponade. So pericarditis patient with hypotension is tamponade. I'm worried about it. Pericarditis patient with JVD is tamponade. I'm worried about it. Pericarditis patient with the muffled heart sound, that is JVD. I'm worried about it. But if they say they have chest pain and that pain is relieved by leaning forward, I'm not going to worry about it. It sounds horrible, but I'm not, because for your test, don't worry. Just to save you some time. A client receiving discharge instruction from LPN. I made it up, but you can see, you know what I'm trying to say. Should you see this patient? What do you think? And I want to see what you guys think. What do you think? You know, the only person who discharge, teach, and assess the patient initially is the RN. So LPN, please don't do that job. It's not your responsibility. So I got to see, intervene. We got to intervene. You can provide teaching at discharge. A client with C. diff, room together with client with MRSA. What do you think? You know what I'm going to say. If you've listened to my YouTube videos, you know exactly what I want to say. 2 words. It's not the precaution, it's the organism. So same organism, but not precaution. C. diff and MRSA are all precaution identical. That means what? Contact precaution, but they are different organisms. For rooming purposes in infectious disease, we have to have same organism. It's a different organism, but they have the same contact. Right? So you don't put them together. So you got to intervene. A client on airborne precaution wearing 95 N95 to radiology department for chest X-ray. What do you think? Should you intervene? It's not needed. All you need was regular masks. That is me letting you guys start thinking. You need regular masks. It doesn't need N95. The only person you wear N95 is the nurses to protect yourself. The patient doesn't need to protect himself anymore. So, yeah, we got to intervene. A client with a client virus being taken by a UA, okay, UAP, 10 minutes within, pay attention, okay, I'm reading for you, I'm emphasizing, but if you're reading it, that's what I want. 10 minutes within initiation of blood transfusion. There's a reason why I emphasize 10 minutes within. Should you intervene? Yeah, you should intervene. The RN should take vitals the first 15 minutes of blood transfusion. After 15 minutes, they can delegate that responsibility to the UAP if they find it necessary. But this one, we have to intervene. We got to intervene because if there's going to be transfusion reaction, it occurs the first 15 minutes. A client on 1/4 normal saline for normal NS of 134. That means sodium. No, I was going to say normal sodium. So yeah, sodium of 134. What do you think? So you're getting 1/4 normal saline for sodium of, I guess it's Na. I put it 134. What do you guys think? So patient is hyponatremic and he's getting 1/4 of normal saline. He's getting hypotonic saline. You should not be getting hypotonic saline for hyponatremia. You should get hypertonic saline, 3%, 5%. So this is a problem. So you should not be getting it, switching into things. A client with large right lobar pneumonia. This is me trying to be an examiner, but I'm trying to trap you. I'm just telling you. Right, large lobar pneumonia and a temperature of 102 receiving antibiotics. What do you think? I only give you the idea what I'm trying to do. Patient just have pneumonia and we're treating it. It doesn't matter if the pneumonia is bigger than the patient. You're not supposed to worry about it. I just describe it to make it sound like horrible. You know, large, right, lobar pneumonia, and its temperature is 102, but we're training it. I never say the patient is having shortness of breath, respiratory distress. All I gave you was this: work with what they've given you and don't make it up. Don't add any more information they've not provided. Oh, it will be in respiratory distress. Anticipate it. That's what, I mean, you've been taught before. They'll tell you anticipated. No, I don't do anticipated because I think everybody will have anticipated problem. We want to work with what we have right now, right down. 10 seconds, what are we seeing? He has pneumonia, he has fever, I expect, because he has pneumonia, and he's getting antibiotic. What else? I'm not told anything, so I'm not going to make anything up. A client with acute glomerulonephritis with T-colored urine and proteinuria. Should you worry about this?
Yes, no, you don't have to worry. It's T follow urine as expected, proteinuria. It's expected.
So this is what you see with glomerulonephritis. Nephritis, glomerulus, destruction of the glomerulus. And so the kidney cannot do its function, so you see some blood. So T chelate. And protein will leak. What should you worry about? They will tell you that kid has edema in the face. Don't worry about it. Periorbital edema. Don't worry about it. The only thing you worry about is hypertension. If the blood pressure goes up from the fluid overloaded, yeah, then they get cerebral edema. So only thing you should worry about glomerulonephritis or nephrotic syndrome is hypertension. If they tell you the blood pressure is very high, yeah, they will have encephalopathy and you have to intervene. But this one, I'm not worried about it. And so that's the 48th question that I made up. Sorry, guys, but it's just like, just like prioritization. Most of the trying to cover every area of the that I think is necessary, but made up questions, okay? Just to get you guys thinking. Any question before we go to? This is just to like, I just want to synthesize some of the key things that you guys know. It may be floating in your head, but you can't see it well, but that's the way they would set it and they can trap you. But when you read, you should do the same thing to yourself, and see if it help you. That's the note to revise. Okay, you're reading short notes. Oh, this is what I should worry about. You circle it. You get a medication. Oh, I give you like maybe what kind of medication, like metformin, example, like that. You're reading metformin, okay? You say, oh, it causes a lot of problem. Nausea, okay, GI symptoms, okay? Lactic acidosis. You say, oh, which one should I worry about? Lactic acidosis, that's number one. Then you circle it. So a patient who is on metformin, you should avoid lactic acidosis formation. How? When you're going to have contrast, okay, you should hold it 48 hours. Then you circle, you put it there. So I'll give you a question. Somebody who is diabetic and then is on metformin and is getting CT scan. You say, oh, no, hold on a second. We got to hold the metformin 48 hours. So then you intervene. Then you circle that. You'll never forget that. Okay.